Hi, everyone. I'm Muriel Finkel, and on behalf of the ASG, we welcome you to our Insurance Medicare webinar. We're really excited to be able to offer this timely webinar and are truly grateful that Monica Fawzy Bryant is taking time out of her schedule to give us this valuable information as well as answer some of your questions. We will tackle the questions that were emailed in, and then if time allows, we'll take on those that are entered in the Q&A section. You won't be able to make or post comments in the chat, but please do check it out periodically, as Bob and Paula will be posting links and other information in there. This webinar, as all of our webinars, should be available for viewing in our on our website and in our YouTube channel about 2 weeks. Also up on our website is our schedule of in-person meetings. We have 4 more scheduled this year: Chicago, Salt Lake City, Boston, and Phoenix. And I hope to see you at one of them. Or if you're a groupie, you can come to more than one. We're joined today by our Special Projects Director, Bob Gibson. And Paula is a little under the weather today, so she's joining us, but we're not going to see her. But she will be posting some things in the chat for us. And our very special guest, Monica Fawzy Bryant, cancer rights specialist, author, speaker, and CEO of Triage Cancer. There'll be a quick survey when this meeting is over, and we ask that you please take the time to fill it out. If you have to leave early, we ask that you fill it out when you leave. It is important to us and helps us in developing future webinars. Okay, so without further ado, Monica, take it away.
Thank you so much, Muriel, and thank you to all of you for joining today. We are going to spend some time talking about health insurance, and I have your questions that were sent ahead of time. So based on those questions, a large chunk of today is going to be focused on Medicare and the upcoming changes related to Medicare coverage. But just to give you a little bit more background about who I am and why I'm the person here talking to you today, I am the co-founder and chief operating officer for an organization called Triage Cancer, where we provide free education on all of the legal and practical issues that come up after a serious medical diagnosis like cancer. But over the years of doing this, we realized that these issues are not unique to the cancer community, and we want to make sure that anybody dealing with any sort of serious medical diagnosis, like amyloidosis, has the same information or same access to this information. So we recently launched a program called Triage Health, where we are providing the same information, but not specific to cancer. So throughout today's presentation, I'm going to point you to places where you can get more information, either about today's topic or other topics like employment and disability insurance, for example. And you can find both of those on triagecancer.org and triagehealth.org. So with that as background, I want to talk about some terms that are commonly used and often confused. And these terms are used in every type of health insurance, whether you buy your health insurance from a company directly, whether you buy through the marketplace or get it through your employer, or whether you have Medicaid or Medicare. So there is a cost that we have to pay every single month just to have health insurance, and that's referred to as a premium. And we're going to pay that monthly premium whether we go to the doctor that month or not. It's like having car insurance all year, but never getting into an accident. But then when we actually go and use our health insurance or access healthcare, there are some additional costs. And the first is your annual deductible. This is a fixed dollar amount that is going to depend on the policy. So some people might have a $500 deductible, you might have a $5,000 deductible, and everything in between. You have to pay your deductible first before your health insurance kicks in. Once your health insurance kicks in, you'll then pay your cost share or your co-insurance. And here we have 2 words for the same thing. So co-insurance and cost share can be used interchangeably. And this is a percentage. And it's the difference between what you have to pay percentage-wise of your medical expenses and what the insurance company has to pay. So if someone has an 80-20 plan, once they've met their annual deductible, they're responsible for paying 80%. Excuse me, the insurance company pays 80% and the individual is responsible for 20%. Then there are many plans that have an additional payment called a copayment. And this is, again, a fixed dollar amount that's going to depend on the policy, but it could also depend on the service. For example, very common to have a $20 copayment to go see your primary care physician, but a $35 copayment to see a specialist, or a $250 copayment if you end up in the ER. It is possible that someone would have to pay both a copayment and a co-insurance for the same service. Now, one of the most important things to understand about your policies, again, regardless of where you get it, is if there's an out-of-pocket maximum, and if there is, what's it made up of? Because the out-of-pocket maximum is a fixed dollar amount that represents the most you're going to pay for your medical care in that year. For some policies, that means adding up everything you pay towards your deductible, everything you pay towards your copayment, and everything you pay towards your coinsurance. So it's everything you're going to pay except that monthly premium. And once you hit that amount, then your insurance is going to pay 100% of your health and care expenses for the rest of the year. And all you have to continue paying is that monthly premium. So I want to give you an example of how this works, and it's a very simplistic example, but we think it's helpful to put this all into context. Meet Dan. Dan has a plan with a $2,000 deductible. It's an 80-20 coinsurance, and he has an $8,000 out-of-pocket maximum. Dan hasn't gone to the doctor yet this year, but he gets into an accident and ends up with a $102,000 hospital bill. So what does he have to pay? Well, the first thing we always have to pay is that deductible. So he pays his $2,000, it leaves $100,000 of the bill. Now his co-insurance kicks in, insurance covers 80%, and he's responsible for 20%, or in this case, $20,000. But Dan doesn't have to pay that $20,000 because he has an out-of-pocket maximum. So because he's already paid $2,000 in his deductible, once he pays another $6,000 of that bill, of that $20,000 bill, he's paid a total of $8,000 out of pocket, and insurance picks up the rest. Now, I'm not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start to look at the alternatives of what he would have to pay without the out-of-pocket maximum, which would have been $22,000, or certainly without insurance, the out-of-pocket maximum and understanding it helps us plan for a worst-case scenario. I often find when I'm doing these types of presentations that someone says in person, oh, I wish so-and-so could hear this. The good news is they can. Everything I just went over in the terms and this example is included in one of our animated videos called Health Insurance Basics. It's about 6 minutes long. It's available in English and Spanish. You can view it for free on our website. Now, I said that Dan is a simplistic example, and the reason is the devil's in the details. So when we talk about out-of-pocket maximums, there are lots of details that are important to understand. For example, there could be an out-of-pocket maximum that only applies to in-network services. So if someone decides to go out of their network, that anything they pay for those out-of-network providers isn't going to get counted towards their out-of-pocket maximum. For people who have an individual plan or a plan through their job, they might have a family plan where multiple family members are on the same health insurance plan. And in those situations, that person has an individual out-of-pocket maximum, but then the family collectively could have a separate family out-of-pocket maximum. I mentioned that for some plans, the way we get to that out-of-pocket maximum is we add up everything we pay towards the deductible, the co-payments, and the co-insurance for both medical care and prescription drugs. And that is true if you have purchased a plan through your state health insurance marketplace. The Affordable Care Act actually mandated that all those plans include all of those types of payments in the out-of-pocket maximum. But if we're talking about employer plans, and we're going to talk more about Medicare in a moment, it could look a little different. So for example, some employer plans might carve out deductibles. So they're only going to look at your co-payments and your co-insurance. Some might not include co-payments. So we're only looking at co-insurance. Some might not include prescription drugs. So the message here is that if you have a non-marketplace plan that isn't Medicare, it is important to understand how your plan defines their out-of-pocket maximum in addition to what is that dollar figure. I know that for this community, prescription drugs is a really big concern. So I want to just level set on a couple of terms that I'm going to use. So every insurance plan or policy has a formulary, which is really just a fancy name for the list of drugs that that insurance company is going to cover and at what rate. So most formularies are broken into tiers or levels, and depending on the cost of the drug to purchase, the amount that the patient is going to pay is different. And this is just an example of what a tier might look like. For example, you're going to have the cheapest generic drugs in tier 1. We're talking about like your penicillin. This is probably going to be something where you go in and have to pay a $5 copayment to pick up your penicillin. Then in tier 2, you're going to have more expensive generic drugs. Maybe they're just recently a generic option. Maybe they are a preferred brand name. So that means that the insurance company is preferring that someone takes that drug. Usually it's because it's a less expensive drug. In tier 2, instead of $5, you're going to pay $30. Tier 3 might be the more expensive or the non-preferred brand name. Again, maybe here you're going to have a $50 copayment. And then you have tier 4 or 5, depending on the plan. And this is where you're going to see specialty drugs and newly approved drugs. And this is often where the drugs that you all might be accessing, and certainly many of the people in the cancer community are accessing, are going to fall in this highest tier. And here, we don't have a dollar figure copayment. Instead, here, we have a co-insurance, which is a percentage. And so I often say, okay, well, 20% of a really expensive drug is a lot of money. And so it is helpful to understand as well where the drug that you're taking falls into your plan's formulary, because it's going to help you figure out what your costs are going to look like. So with that sort of level setting us, let's move into Medicare. Medicare covers about 20% of the US population, and in order to access Medicare, you do have to be a US citizen or a legal resident, and you have to be 65 years or older, or be under 65, but have been receiving Social Security disability insurance for 2 or more years, or have end-stage renal disease or ALS. Those are the only ways to access Medicare as of right now. Now, when we talk about Medicare, it can be a little bit tricky because we talk about Medicare as if it is one thing, when in reality, it is actually 4 or 5 things, depending on how you look at it. And that's because Medicare is broken up into parts, and each part covers something different and has different costs associated with it. So Part A is hospital insurance. So this is going to cover anytime you're inpatient. It does cover hospice care, some limited skilled nursing facilities. If someone has worked and over their career paid into the system, Part A is what's called premium free. So there is no monthly premium to access Part A. If you haven't worked enough quarters, then you can still access Part A, but you do have to pay a monthly premium. There's also a deductible per benefit period and some co-payments. So there's sometimes a misconception with Part A that it's all free, when in reality, the piece about Part A that's free is typically the premium. So Part A is hospital insurance. Part B is medical insurance. And so this is where services like doctor's visits, outpatient care, preventative services, labs, imaging, IV chemotherapy, and other IV drugs are all going to be covered under Part B. With Part B, there is a monthly premium for everybody. Now, the amount of the premium is going to be based on your income, but for most people this year, it was about $175. One of the challenges about talking about Medicare at this time of the year is that we don't yet have 2025 numbers from CMS. So keep in mind that that $175 a month is for 2024. We don't know what 2025 is going to be yet. For this year, there is also an annual deductible of $240. Then Part B has a cost share of 80/20, which means that once you've met your deductible and you've paid $240 out of pocket, any service you receive, you are going to be responsible for 20% of that service. There is no out-of-pocket maximum in Part B. Part B will never pay 100% of your medical expenses. When we refer to Part A and Part B together, that's what we call original Medicare, because it's all that existed when Medicare was signed into law. And original Medicare is fee for service, which means you can go to any provider around the country that accepts Medicare and get coverage. Any provider around the country. So there is no network in that way. Part A is hospital insurance, Part B is medical insurance. Jumping over to Part D. So Part D is prescription drug coverage that was added to Medicare much later. It wasn't signed into law until 2003. And Part D plans are sold by private insurance companies. Because they're sold by private insurance companies, the costs can vary from company to company. So the range of monthly premiums was between $1 and $108 a month this year, 2024. And that's on top of your Part B premium. There is also an annual deductible with Part D. And we do have that number for 2025. And it means that those plans can pick what deductible they want to have for their plans, but it can't be more than $590 for next year. And then there are some copayments and coinsurances. Medicare Part D is complicated, and we've had some pretty significant changes over the last 2 years, thanks to the Inflation Reduction Act that President Biden signed in 2022. It did some really important things, particularly for communities like yours. So I want to walk through where we are in terms of Part D coverage today, and then I'm going to talk a little bit about 2025 and what's coming down the pike. So the way that Part D coverage works right now is that an individual pays their deductible, which this year can't be more than $545. Then they enter the initial coverage phase. During this time frame, you pay 25% of your drug costs. Then, when your total out-of-pocket drug costs reach $8,000, you enter catastrophic coverage phase where you pay nothing and Medicare picks up the rest. Now, it is complicated, as I've mentioned, because this is only true if someone is taking all 100% generic drugs. If, however, someone is taking a brand name drug, things change. It's no longer $8,000 is your out-of-pocket maximum. The out-of-pocket maximum actually ends up being closer to $3,333. And the reason for that is that during the initial coverage phase, when the beneficiary is paying 25%, the drug companies are actually providing a discount of about 70%. And so the way that it's set up is that the beneficiary is actually getting credit for that 70% discount, which lowers the amount that they actually have to pay out of pocket. So this is really significant because in 2023, there was no out-of-pocket maximum. There was no limit on the amount that someone could have to pay for their prescription drugs. This year, we effectively now have the most someone is going to pay is that $8,000 roughly amount. And if you're taking all brand name drugs, it's even lower than that. So we've made significant improvement this year, but it's still super complicated, and it gets even more complicated if people are taking a mix of brand name and generic drugs. So good news is we now have this out-of-pocket maximum. Bad news is it's still complicated. Next year gets less complicated. And the reason is that for everybody gets treated the same regardless of if they're taking brand name or generic drugs. So here's what we are anticipating Part D coverage to look like next year, starting January 1st. First, you're going to pay your deductible, which can't be more than $590. Then you enter the initial coverage phase. At that point, you're going to pay 25% of your drug costs. Then, when you get to $2,000 out of pocket, you enter the catastrophic coverage phase and you pay nothing. So this is really significant because we've gone from no out-of-pocket maximum in 23 to the highest of $8,000 in 2024 to now it's going to be $2,000 in 2025. So we are making some really significant differences and improvements here. But for someone who has an expensive drug, like many of the ones you are taking, you could actually move in and out of that deductible and that initial coverage phase and the catastrophic coverage phase in January with your first prescription. And with the Inflation Reduction Act, Congress recognized that for individuals who are on Medicare, seniors who often have fixed incomes, and people with disabilities so severe they cannot work, that even a $2,000 amount might be very challenging for someone to pay all at once in January. So they've created this program called the Medicare Prescription Payment Plan. If you've heard me speak before, I referred to it as smoothing because that's what they were calling it until they released the final rules, but now we're calling it the Medicare Prescription Payment Plan. And essentially what this is a payment plan. So you get to spread out your prescription drug costs throughout the year if you are taking an expensive drug. I will tell you, we did get a final rule. I still have some questions about how someone is actually going to enroll in this, but I want you all to know about it so that in January you can proactively reach out to your insurance company and talk to your pharmacist about wanting to join this prescription payment plan if that's what you want to do. So it's definitely going to be something beneficial for people who have high cost sharing earlier in the calendar year. The rules say that the insurance company is supposed to identify if someone is likely to benefit from this plan and send you a notice in the mail. That's putting a lot of responsibility and trust in the insurance companies. So again, I want you all to know about it and not just wait to get a notice, but to proactively communicate with your insurance company and the pharmacist if you want to join this plan. So here's a rough example of how we think this should work. So meet Bob. Bob has amyloidosis and he's taking Vindamax. The estimated monthly cost is $23,525 for a 30 capsule supply. I actually looked it up and that is the current estimated monthly cost. He has a Part D plan with a $35 a month premium. So in January, when he goes to get his Vindamax, he has to pay his $35 monthly premium. He has to pay $545 in his deductible and his co-insurance of 25%. So adding all of that together, he would have to pay $6,325. But because it's now going to be 2025, he doesn't have to pay that full $6,325 because the co-insurance is capped at $2,000. I'm sorry, I did that totally wrong. That should say January of 2025. My apologies. January of 2025, it's capped at $2,000. So what he's going to pay is his monthly premium, $35, the deductible of $545, and then another $2,000 for a total of $2,580. So from 2023 to 2025, that's a significant difference. And then guess what? In February, when he goes to pick up his next 30-day supply, all he's paying that month for his prescriptions is his $35 premium. March, his $35 premium. April, his $35 premium, and he will get his Vindamax for the rest of the year covered. So this is a huge change and hugely beneficial. Now, let's just look about though, if Bob is in a situation where like he can't pay that $2,500 in January, or maybe that's going to be more harmful for him to pay that $2,500, what does it look like if he enrolls in the Medicare prescription payment plan? Well, in January, again, his total cost would be $2,580, but he doesn't want to pay that amount. So he can enroll in this prescription payment plan, and it will essentially, because we're in January, divide up the $2,000 by 12, and he then only has to pay $166 a month for his co-insurance. So in January, what that means is he has to pay his monthly premium of $35. He has to pay the deductible of $545. Then his spread out, divided up co-insurance of $166. So instead in January, he pays $746 instead of that $2,500. And then in February, because he's already met his deductible, he's paying his monthly premium of $35 plus $166 for $201 a month. And he will pay that $201 a month for the rest of the year. I am over the moon excited about these changes because we've just seen firsthand how challenging it is to pay for these really important, but yet really expensive prescription drugs. So I don't see the Q&A blowing up. So hopefully everybody is still with me. So Part A is medical insurance, Part A is hospital insurance, Part B is medical insurance, Part D is prescription drugs. Someone could have to pay potentially 3 different premiums, 3 different deductibles, 3 different cost shares, and that can be challenging for people. An alternative was created in the 80s called Medicare Advantage, also known as Medicare Part C. And these are managed care plans that provide all of the services someone would get under Part A and Part B, but in a managed care format, which means there's a network of providers, there's an insurance company that you're sending a premium to. I will say about 90% of Advantage plans also include prescription drug coverage. So you could have a situation where you're getting your Part D coverage without an added premium. A lot of them also cover extra things like transportation to and from doctor's visits, or gym memberships, or all sorts of things. The cost for Part C is going to vary. The national average for Part C is $18.50 a month. But do not be misled by the commercials that you will inevitably see around October when open enrollment happens. When they talk about get your free Medicare, what they mean is your Part C plan isn't going to cost you anything extra. Everyone still has to pay at least their Part B monthly premium. There is no way to avoid that in this context. With Medicare Advantage, there is an out-of-pocket maximum. So with Advantage plans for in-network medical services, so that's anything that's covered under A and B, the out-of-pocket maximum is $8,850. So that's really one of the benefits of these Advantage plans. A significant downside, though, is that network of providers. And so people have to think very carefully about, is it more beneficial to have the out-of-pocket maximum and some of the extra benefits, or is it more beneficial to be able to see any provider around the country? If someone is interested in an Advantage plan, that when they're trying to compare two options, then they actually have to look at what's the premium, what's the deductible, and what's the out-of-pocket maximum. And then they're going to take that monthly premium and multiply it by 12, because that's how much you're going to pay for the year. And then you add the out-of-pocket maximum. And when you do that for all of the plans you're considering, you'll actually be able to get a sense of which is going to be the least expensive option at the end of the year. So when someone is considering a Medicare Advantage plan, certainly we have to do the math and look at the various costs, but it is imperative that they also look at the networks of providers and facilities. Additionally, if someone picks a Part C plan that has prescription drug coverage included, then they need to look at what drugs are covered, the formulary, and all of those pieces. Oftentimes people will say to me, well, wait a minute, which is better, original Medicare or Medicare Advantage? And I will say it depends. So it depends on somebody's needs and potentially where somebody's located. The out-of-pocket maximum is certainly a benefit, and that you are getting additional things for the same amount of money you would pay just to have Part B. Again, the major downside is you are dealing with an insurance company and the limited network of providers. And I know there were a number of questions that were sent in around, I want to go see a specialist in my disease, but there isn't one in my Advantage Plans network. What do I do? And it gets really tricky. There are some options to potentially appeal that decision and ask for what's called a network exception. But I would also say that you might have the opportunity at the end of the year during open enrollment to either pick a different Medicare Advantage plan that might have a specialist in their network, or potentially to move over into original Medicare. We'll talk more about that in just a minute. So I am always sort of shocked when I look at this slide about all the things that Medicare doesn't cover. And again, that could be one of those benefits of an Advantage plan, because some of those plans do include some of these pieces that original Medicare might not cover. But if someone's in a situation where they want to be able to go to any provider around the country, so they're interested in original Medicare, but they are very concerned about the lack of out-of-pocket maximum in Part B plans and A, for example, not Part B plans, lack of out-of-pocket maximum in Part B, sheesh, it's the weekend, and in Part A, there's one thing they can do to protect themselves, and that is to purchase an additional plan called a Medigap plan. These are also sometimes referred to as supplemental plans because they supplement or add to the benefits of Part A and Part B. These Medigap plans are sold by private insurance companies, and the options and rules vary from state to state. In most states, Medigap plans are identified by letters A through N, not to be confused with Medicare Parts A through D. Why we couldn't come up with any other naming system for these Medigap plans, I don't know, but they don't put me in charge. Every Medigap plan of the same letter has to provide the same benefits. But because they're sold by a private insurance company, the cost for these plans could vary based on where you are. Now you see plans C and F off to the side. And the reason for that is that if someone becomes newly eligible for Medicare after 2020, C and F are no longer available for purchase. If someone had a C and F prior to 2020, they can keep it as long as they continue paying the premiums. But if you've become or will become Medicare eligible after 2020, you can't buy C and F. The next most comprehensive plan is a Plan G. And the reason is because Plan G covers 100% of that Part B coinsurance and the Part B excess charge. So the way that it works is someone goes to a provider, the provider bills Medicare for the covered service, then the patient's responsible for paying their deductible, their Part B deductible. Then Medicare picks up 80% of the medical costs, and the Medigap picks up the 20%. Medigap is only helpful for things that are covered under Medicare Parts A and B, which is why purchasing a Medigap plan was not helpful for people who had high prescription drug costs covered under Part D, and why these changes that we got through the Inflation Reduction Act are going to be so beneficial to patients. Couple of things to note about Medigap plans. There are generally 2 times when Medigap plans are what's called guaranteed issue, which means that an insurance company has to sell you the policy and can't look at pre-existing conditions or medical conditions when deciding what they're going to charge you. So it's guaranteed issue. And the 2 general times, there's a whole bunch of exceptions, but the 2 general times that Medigap plans are considered guaranteed issue is when you first turn 65 in what's called your initial enrollment period, or if you're in a situation where maybe you worked past 65 and you had employer coverage, so it didn't make sense for you to pay for Part B or Part D, well then when you stop working and lose that employer-sponsored insurance, you have an opportunity called a special enrollment period to enroll in Medicare outside of your 65th birthday. If you are under 65 and you're receiving Medicare because you are on SSDI or receiving SSDI, there are a handful of states where there isn't a requirement that insurance companies sell you the policy. It doesn't mean it's impossible to get the policy. It just means you don't have the right to purchase the policy. And that's a time where if someone's in one of these states and they're under 65, that actually Medicare Advantage might make more sense for them because they can't access Medigap yet. Medicare Advantage is going to give them that out-of-pocket maximum. So I don't want to get too far in the weeds, but the point here is this is just an example of where there is rarely a one-size-fits-all answer. Now, I mentioned open enrollment a few times. Open enrollment for Medicare is in the fall every single year from October 15th to December 7th. That is the opportunity for you to make changes to your Medicare options. And a lot of the questions that I got were about, I'm in this option, but I want this other option. How do I make those changes? Your opportunity to make those changes is during that annual open enrollment period. And then the changes become effective January 1st. When we're talking specifically about Medigap plans and open enrollment, there's some nuances. So first, someone could switch plans within the same letter and not go through medical underwriting, which means that insurance companies can't charge you more because of your medical condition. So maybe I'm in, and I'm making these up, but maybe I'm in the Humana Plan G and I want to go to the AARP Plan G. If I'm going from Plan G to Plan G, they can't charge me more because of my medical condition. I can also go down in coverage, although I'm not sure why someone would do that, but maybe there's a valid reason. You can also get a plan if you haven't had one before or move up in coverage. But if you haven't had one previously, like maybe, for example, you were in Medicare Advantage and now you want to be in original Medicare with the Medigap, or you're trying to increase coverage, then you actually could get denied. You could be charged more, and you could face a pre-existing condition exclusion period. So that's up to 6 months where you are paying for this Medigap plan and it isn't covering anything related to your pre-existing condition. Now, if you go break your leg, it'll cover the ER visit, but if you're covering your amyloidosis treatment, it's not going to cover it for 6 months. So sometimes people will look at that and think, well, it's not actually worth it for me then. I shouldn't do that if I'm going to face this exclusion period. But you do have to actually do the math to figure out, because even with a 6-month exclusion period, you could save a considerable amount of money, particularly if your treatments are covered under Part B. And then every year after that, as long as you keep the policy, it's going to cover anything related to any of your medical care under Part A and Part B. So even if you're in a position where you're trying to move back into original Medicare and you might face a 6-month exclusion period, it is really valuable to do the math to figure out, am I going to save money in the long run? And then have all the benefits of original Medicare, like going to any provider around the country. So one of the, if I didn't sort of make this clear already, one of the challenges with figuring all of this out, particularly for your community, is you have a number of drugs, and depending on the drug and how you're receiving it, those drugs could be covered under different parts. So generally speaking, when we are trying to figure out which part of Medicare something is going to be covered under, and the reason we care is because the amount we're going to pay is going to be different, we want to look at where is the drug administered. So if it's administered inpatient, like in a hospital or a skilled nursing facility, then it's actually covered under Part A. If it's something where you go to an infusion clinic and the provider is actually administering it, like an IV chemotherapy, for example, that's going to be covered under Part B. And remember, Part B comes with that 20% coinsurance and no out-of-pocket maximum. If it's something where you go to the pharmacy and you pick it up and then you take it, that's going to be covered under Part D. Seems simple, right? If only wishing made it true. Because it can get more complicated depending on the exact type of drug. So for example, if we're over here on the right, if someone's taking an oral chemotherapy that used to only be available as an IV, even though they're picking it up at the pharmacy and they're taking it, it's still going to be covered under B. So I'm bringing this up because I just want to make it clear that it is not always cut and dry as to what part it's going to be covered under. And if you have any questions about that, depending on your circumstance, that's certainly something that you could call and talk to your insurance company about. Now, one of the other challenges with Medicare, and frankly, all health insurance, is that even if something is technically covered, it doesn't mean that there aren't going to be high costs. So there were some questions about other types of drugs, and if they're going to receive a denial from their insurance company, what do they do? And certainly there is an opportunity to appeal, which I'm going to talk about in just a minute. But also, I just want to really empower all of you to think about, if you're in a situation right now where you feel like the plan you have is not meeting your needs, you aren't stuck with it forever. We do have that option. And this is true within Medicare and out of Medicare, with individual insurance and employer insurance. Every year, we have the opportunity to look at all of our options and try to find something that meets our current needs. So to sum all of this up, when someone is trying to figure out their Medicare options, there's two lanes they get to drive in. Lane one is original Medicare. So this is where we get Part A for our hospital insurance. We pick up Part B for our medical insurance. Then we decide, do we want coverage for prescription drugs? Hopefully the answer is yes. And we purchase a standalone Part D prescription drug plan. Then we've asked, well, wait a minute, Part A and Part B don't have out-of-pocket maximums. So how can we protect ourselves from those potentially unknown costs? The way to do that is to purchase a Medigap supplemental plan. As a reminder, lane one is fee for service. Any provider around the country that you want to see that takes Medicare. The alternative is lane two, which is Medicare Advantage. It's where you're purchasing a managed care policy. That policy, sold by a private insurance company, is going to bundle all of the services that you would get under Part A and Part B. If you pick one of the 10% of Advantage plans that doesn't include prescription drug coverage, then you can pick up a standalone Part D plan. And that is where your options end in lane two. You cannot buy a Medigap plan if you are driving in lane two. And the reason for that is lane two comes with an out-of-pocket maximum. The other piece about lane two is that it has that limited network of providers. So I want to go through this again, looking at costs. So Jimmy is a situation where he's nearly 65. He's about to begin 1 year of IV chemotherapy treatments, which is going to cost him which will cost $10,000 a month. Because he's getting the IV chemotherapy in a doctor's office, it will be covered under Part B. What will be his costs? The important other piece of information is Jimmy spends half his time in Illinois, in Chicago, and he spends half his time in Florida. So, looking at his costs under original Medicare, we have to pay Part B monthly premium, so $174.70 times 12 for the 12 months, about $2,000. He has to pay his Part B deductible of $240. Then he has to pay his Part B coinsurance of 20%. So just looking at his chemotherapy to make the math easier, we're not talking about any other medical care, $10,000 a month times 20% is $2,000. $2,000 times 12 for the year is $24,000. So under original Medicare, his costs just to have Part B and get his IV chemotherapy is $26,336. So looking at his same situation with a Medicare Advantage plan, still has to pay his Part B monthly premium. You never get out of that. We've even given him an Advantage plan that doesn't have an additional Part C premium. And his coinsurance is, again, $10,000 a month times 20%, $24,000. But because Advantage plans have that out-of-pocket maximum, the most he's going to pay for his coinsurance is that $88.50. So here with Advantage plans, we've already saved him approximately $15,000, which is great. But remember, we talked about the fact that he spends half his time in Illinois and half his time in Florida. He likely won't be able to find an Advantage plan with a network that's going to have doctors in both places. So the last alternative is original Medicare with a Medigap Plan G. Again, you still have to pay the monthly premium for Part B. You still have to pay the Part B deductible. We've estimated here that his Plan G is about $300 a month for $3,600. But that Plan G is going to pick up the entire 20% coinsurance. So he will pay $0 for that coinsurance. And when we look at that, the math gets us to $5,936. So half of what he'd pay under Advantage. And because it's original Medicare, he can go to any provider around the country that takes Medicare. So we like this math because sometimes it's counterintuitive to think about purchasing another plan to save money. But as you can see, for somebody with an expensive medical condition, particularly when the drugs are provided are given by a provider and covered under Part B, Medigap plans can be incredibly helpful. And now we also have the upcoming $2,000 out-of-pocket cap in Part D. So things are definitely moving in the right direction. I mentioned that we have options each year to make changes. Also, when you first become eligible, it can feel very daunting to do all of this math and figure it out. We have a free printable worksheet where you can actually print it out and fill out the questions, and it helps you do the math to compare the various plans. I will also say that there are some other places where you can potentially go for help. So if you actually call 1-800-Medicare and say agent, you will talk to a real life human. Shocking, I know. Every state also has a state health insurance assistance program or a SHIP program. These are called different things in different states. For example, in Florida, I believe it's called SHINE. In California, it's HICAP. In Illinois, it's SHIP. If you are looking for the SHIP program in your state, we do have all of those listed on triagecancer.org, where you there's a map, you click on your state, it'll give you the name and the contact information for your local SHIP program. These SHIP programs are incredibly useful. They're trained to help people walk through their different Medicare options. They can be helpful with appeals or applying. So I highly, highly, highly recommend taking a look at your SHIP program if you're making Medicare decisions and you have questions. We also at Triage Cancer have 4 animated videos on the parts that I talked about today, and then also one on the different enrollment periods that might be applicable to you. And we have tons of Medicare resources. So I mentioned our worksheet, but we also have quick guides and videos and recorded webinars. So if you want to learn more about Medicare, or if you have another type of health insurance, we also have a health insurance resource hub as well. And everything that you find on these websites, you can access 100% for free. And even though I know we spent a good amount of time today talking about Medicare, we really just scratched the surface. It is also sometimes helpful to hear this information more than once. So I did just want to mention, we do have an upcoming free webinar. It's a 90-minute webinar on the 26th that you can sign up for and join to learn more. And we actually are hoping that maybe we might have more of the 2025 numbers by that point. We just are waiting on CMS. And then finally, as promised, I wanted to talk a little bit about what people can do when they're in situations where their insurance company says no. And this is definitely applicable across the board with individual insurance, employer-sponsored insurance, and also with Medicare. The details vary slightly depending on the type of insurance you have. But the idea here is that you shouldn't take no for an answer. When we're talking about individual or employer-sponsored insurance, there are at least going to be two levels of appeal. The first is where you're going back to the insurance company and asking them to reconsider. The second, if the insurance company is still saying no, is what's called an external appeal. And this is where you go to an independent entity and ask them to look at their situation or your situation. And the decision of that independent entity is binding on the insurance company. Appeals is one of those things that is frustrating to talk about because it's adding one more thing to your plate, which we can totally appreciate. There's too much on your plate. However, about 60% of appeals are decided in favor of the patient. And so it is worth your while to try to appeal the denials. When we're talking about Medicare, there's 5 levels of appeal. There's a huge hurdle in knowledge. Even healthcare providers don't know necessarily about the external appeals process. And so you might be in a situation where you are having to inform your healthcare providers about it. To help you do that, if that becomes necessary, we have lots of resources that you can access. And I'm going to certainly try to stay on and answer as many questions as I possibly can, but I want you to know that if after today you have additional questions that we aren't able to get to, please feel free to reach out to us via the Legal and Financial Navigation Program. You can fill out a form on our website, tell us what your question is, and then schedule an appointment to call to speak with us. We'll give you a call at that time, and we'll try to explain your various options and the pros and cons of those options. So I appreciate you all again being here and your grace with the things that we cannot control in life. And I'm going to turn it over to Bob with that, and I will start taking a look at the questions in the chat box.
Thank you so much, Monica. Like any good presentation, it generated more questions, and we've got lots for you. But first, we'll give you a little break, your vocal cords, a few minutes break, okay? And Bob's going to fill in for Paula today, who doesn't have her voice with her today. And Bob will tell us all about the financial aid that's available. So Bob, take it away.
Well, let's go and share the financial aid presentation that Paula has provided. I'm pinch hitting for her today, and we'll be talking about the programs that are available to amyloidosis patients here in the US. So let's get that teed back up. I'll begin with the assistance grants that are offered by several different charity organizations. All of these grants are funded through donations, and they're likely to open or close to new or repeat applicants several times each year as funding levels change. Most have wait lists that you can sign up for to receive notifications when the fund reopens. When these funds are open, you're going to want to apply as quickly as possible. There's a lot of competition for them, and if you're slow to apply, you may miss out. The HealthWell Foundation has 3 main funds that help cover the cost of your medicines. Their amyloidosis fund does not require you to be on Medicare and will cover up to $8,000 in copay or premium assistance. The coverage decision is made when you first apply for assistance, and you are allowed to change this designation once during your coverage year, which begins the month you are approved. The next two funds do require Medicare coverage to qualify. For those of you with AL and myeloma, your myeloma fund will pay up to $12,000 per year. The cardiomyopathy fund pays up to $10,000 per year and historically stays open more often than the other two funds. The Patient Access Network, more commonly known as the PAN Foundation, will cover up to $3,250 per year for out-of-pocket medication costs, insurance premiums, and even transportation expenses. The Assistance Fund offers grants for amyloidosis and heart failure that cover out-of-pocket costs for copays, deductibles, and coinsurance. The Patient Advocate Foundation offers $7,500 per year for myeloma patients who are covered by Medicare, Medicaid, or military benefits. Their fund for amyloidosis covers up to $5,500 per year for copays, coinsurance, deductibles for medical and office visits, and medical insurance premiums. All types of insurance are accepted for this fund. The Leukemia and Lymphoma Society offers copay assistance to patients who have been diagnosed with a blood cancer and amyloidosis. Patients with myeloma can qualify for up to $5,000 annually, and those with Waldenstrom's macroglobulinemia, $4,000. Assistance is also available for those with lymphoma or leukemia seen in conjunction with AL amyloidosis. The National Organization for Rare Disorders, of which Amyloidosis Support Groups is a member, recently announced a new fund for amyloidosis patients. It offers financial assistance to cover health insurance premiums, deductibles, co-payments, and coinsurance costs. Paula, I believe, will be putting links up to these programs in the chat, so please check there for information. To qualify for any of the assistance I've mentioned, you must first meet the annual income criteria set by each specific fund. Those amounts are based on the federal poverty guidelines. Try and say that 3 times fast. The federal poverty guidelines you see on this chart. For most of these funds, your annual household income must not exceed 500% of the federal poverty guidelines, based on the number of people you have in your household. The Leukemia and Lymphoma Society is a bit more generous and allows you to make up to 600% of the poverty guidelines. If you live in Alaska or Hawaii, your income guidelines are based on the tan and green columns on this chart. There are additional exceptions to the annual income criteria for those who live in an area with a higher than normal cost of living index, such as large metropolitan areas of the country. If your income is close to the cutoff amounts shown for your household size, be sure to contact the organization you are applying with directly to see if there is a cost of living adjustment available in your location. Lastly, let me discuss assistance programs that are available from the pharmaceutical industry. The website shown can connect you to the various companies that have FDA-approved treatments for amyloidosis. If you are uninsured, underinsured, or low income, I urge you to contact the appropriate company to see if you may qualify for assistance with them. They all have trained staff available to help you with questions or concerns that you may have about affording your treatment. For more information, just visit www.amyloidosissupport.org, or you can email Paula as well at paula@amyloidosissupport.org. Hope I filled in for Paula adequately, and thank you very much.
Well, you're not as pretty, but it's okay.
Yeah, thank you.
Okay, we've got a bunch of questions that were mailed in. And some of them were kind of personal, and I did send them to Monica, and it might require a little individual, work on her part, but she'll do what she can with those. But let's take some that are of general, interest to most people, okay? So Monica, This person says, if my condition has worsened, I have other comorbidities, and I'm now considering hospice care. Will Medicare still pay for Vindamax?
Generally speaking, once someone enters hospice, then typically they aren't going to continue receiving curative treatments. But that's actually, Vindamax is a little bit of a unique situation. So I'm not sure I could answer definitively, but that's certainly something that you could ask whomever is helping you with the hospice process to know whether or not Medicare is going to continue covering that, or if it's even appropriate to continue taking it, medically speaking.
Okay, great. Okay. I read that Medicare medication costs. Okay, this is okay. Okay, well, this one was already answered. I'm a patient taking Vindamax, will be turning 65 next year. Okay, that was all of these were answered. Wow, you're great. Okay.
I tried.
Okay. Since so many AMI patients are now eligible for organ transplants, including me, I was wondering if the speaker could address Medicare insurance coverage on anti-rejection drugs. I believe there is some coverage for kidney transplant patients, but I personally have had a heart-lung transplant and am very interested in learning about my options. Okay, and then they thank you so much and think you're wonderful, just like everybody else does. And that's from Denise.
Well, thank you. I appreciate that very much. So generally speaking, if a drug is medically necessary because of a medical procedure that you've had, that should be covered under Medicare. I believe, again, remember, I'm a lawyer, not a doctor, but I believe that those would be oral medications that you were taking. But if you're inpatient while you're taking them, like it's, after a bone marrow transplant, for example, and you're still inpatient, that's going to be covered under A. If you're taking it outpatient, if you're getting it from a pharmacy and taking it, that's covered under D. So it should be covered. It's just a question of which part is it going to be covered, because that's going to then determine the costs that you are responsible for. Right? Because there's a difference between covered and free.
Gotcha. Okay, this person says, my husband receives an Amvuttra injection by an RN coming to our home to administer it. When he becomes eligible for Medicare, is this method covered, or will he have to go to a doctor's office? He's concerned about exposure to patients with COVID and other illnesses. Well, this is interesting, Monica, because the precursor to Amvuttra is patisiran on Patro, which was done by an infusion, where Amvuttra is a subcutaneous shot where people have to go get it done. There's a bill before Congress right now, the Joe Fiandra Home Infusion Act, because home infusions are not covered under Medicare. And so we think that this is going to be sponsored very soon in the House and then hopefully in the Senate. So hopefully it won't be an issue. But for now, are there special cases where people can get that coverage?
Generally, no. You could certainly try to use the appeals process to show why it's medically necessary that you receive that at home versus in a outpatient facility, but it is going to be a heavy lift, which is why the legislation that you just mentioned is so incredibly important. And I will tell you that the elected officials need to be hearing from patients that this is going to impact. They need to hear the real stories and see the real faces. If you've never engaged in legislative advocacy and you'd like to learn a little bit more about how to go about doing that, like the really practical pieces, we have a number of resources on our advocacy hub that walk you through the steps to take to engage in legislative advocacy, because it's so incredibly important that elected officials are hearing from the people that the legislation is going to impact.
Great. This is interesting. Okay. I am currently being treated with vutrisiran, or Amvuttra, as we also call it, in France, where I live. All costs are covered by the French health system. I plan to come back to the US, so I need to sign up for Medicare B and D. How long before they would approve and pay for my treatment? I would like to time my move so not to have a lapse in treatment.
So I would actually love to talk to that person a little bit more individually. So that person can certainly reach out to us via triagecancer.org/get help. But moving back into the country would trigger that special enrollment period where someone actually has 8 months to pick up new coverage. That process can be started before the move happens. And the SHIP program might be a great place to go to start that, even like on the phone, to start that process, so that once you come into the country, everything is good to go and coverage will start. And that's true whether someone's moving into the country or maybe someone's moving to a new state and they're on Medicare Advantage and they need to switch plans, or they're about to retire and leave their job. So that same advice applies anytime there's going to be someone who is eligible for a special enrollment period into Medicare.
Okay. Oh, this is on a specific drug, Revlimid, okay, which is it's listed under the IMIDs in our AL treatment. And this person wants to know, how much will Medicare cover of Revlimid or its generic counterpart?
So Revlimid has been a tricky one for us this year because it's covered under Part D generally. And remember I said for people who are taking generic drugs, the out-of-pocket maximum could be as high as $8,000. People taking brand name, it's $3,300. So many Medicare plans said we're only going to cover the generic version because it's less expensive, which means people taking the generic version were paying more out of pocket. In 2025, it should be a moot point because everybody should have the $2,000 cap, regardless of whether you're taking generic or brand name.
Okay.
So stay tuned a few more months.
This is kind of HMO versus PPO question here. In March, I was diagnosed with hereditary. I have a Medicare HMO, would like to see a doctor outside of my HMO. I can't switch to a PPO until open enrollment, and then won't be available until January. I'm not even sure I can afford the PPO. My question is there financial support to go and see doctors at centers of excellence who have been treating this type of disease longer?
So this is a unfortunately perfect example of the challenges with Medicare Advantage plans. That individual could potentially try to appeal with their HMO for a network exception, but you're going to have to come up with a strong case as to why seeing that other provider is medically necessary. And so that's tricky because sometimes people are like, well, there is a doctor that could treat me, but I want to go to the expert or the specialist, which I personally completely understand. But the insurance company might say, we have someone who can treat you in network. We're not going to approve that. With respect to the point around next year, the other option, so one option, yes, is to try to go in a PPO and see if that helps. But remember, you could also switch lanes entirely back into original Medicare. There is some financial assistance in Medicare specifically called Medicare savings programs, depending on your income level. But I think the question is also asking before then, is there any sort of financial assistance to help me pay for these doctors? Generally speaking, not that I know of off the top of my head, but there's certainly on our website, we have a tool called cancerfinances.org where we have a financial assistance module, and you could certainly go through that to see if there are places where you might be eligible for financial assistance, and think creatively. You might not be able to find help to pay for the doctor that's out of network, but maybe you can find help for your utilities or your groceries or your gas, and then shift the money that you have for those things to help pay for those higher out-of-pocket costs.
Great. Okay. This
Hey,
might have been answered.
Muriel, this is Bob. Can
Yeah.
I add to that?
Sure.
Some of the centers of excellence for treatment for amyloidosis do have foundations. They may not be specific to amyloidosis, but they do have foundational support for patients who go to the institution. For example, I know that the Boston University Medical Center does. Whether or not they would cover the types of expenses that the question's being asked about, I don't know. But that would also be a source of, that I personally know about in terms of the Boston University Medical Center, looking into that and seeing where Maybe they do cover travel expenses. Maybe they do cover some of the affiliated costs. So it would be worth looking into for individual institutions.
You remind me of something that happened with a patient last year where they did not have the insurance that would cover them going to a specific center, but since that center had seen their entire family and it was hereditary, they did umbrella that particular patient in. So I guess it's kind of worth inquiring if your family has been going to a specific center. Okay. Here's, I plan to continue with Kaiser and sign up for the Medicare Kaiser plan. How is the cost for Amvuttra going to be determined? I currently have Kaiser through my work and have zero copay.
Remind me, because I can't ever keep them straight. Is that an infusion or an...
Amvuttra is the subcutaneous shot, but you do have to go to what center to have it done.
Right, that's right. Sorry. So that's likely going to be under Part B then, which means it's going to be 20% up to your out-of-pocket, well, yeah, up to your out-of-pocket maximum of about $8,000 for your Medicare Advantage plan.
Okay. Is it possible or likely that all or most Part D plans not list Vindamax on their formulary, therefore not offering any coverage for anyone needing the drug? What is involved in each plan's decision to include or exclude particular drugs in their plans? I've been reading the expense of the high tier drugs have been a part of some of the Part C plans reported to no longer going to be offered next year.
So Medicare does have some rules around what drug, that there has to be drugs in every class, but when there's competition between, there could be a preferred drug, one over the other. So it is a complicated answer that I'm not sure I want to get into today, but what I will say is that as consumers, you do actually have some control over what plans you're choosing. And if you're looking at Part C plans that have drug coverage and it doesn't include the drugs you need, considering switching back over to original Medicare and picking up a standalone Part D might be the better option for you.
Okay. I'm on acoramidis. Acoramidis is a pill that drug that will be in competition for Vindamax, and we expected it has a PDUFA date for approval by the FDA in November. So that's the drug this person is referring to. I'm on acoramidis, which will probably be approved later this year. How do I determine which Medicare supplement will cover the drug when I need to sign up before the end of the year? Would that be the same as Vindamax since it's a pill? And
right. So supplemental plans or Medigap plans are not going to help with those costs because those are going to be covered under Part D. Supplemental / Medigap plans, 2 words for the same thing, only help with costs for A and B. But as we just talked about, in 2025, there's going to be that $2,000 out-of-pocket cap for her prescription drugs. And she could potentially enroll in that payment plan where she could spread out that cost throughout the year.
okay. Well, this is the question on home health. What and it was covered, but I guess it bears repeating a little bit. What are the specific Medicare available supportive benefits related to home health for amyloidosis patients as the disease progresses?
It's going to depend. Home health is generally something that's covered in Advantage plans, so it's going to depend on the plan, and it's not something that I can really speak to generally.
Okay. Okay, that's Medicare. Okay. Are Medicare Advantage plans required to provide specialty transplant hospitals in network?
I'm not sure what you mean by specialty transplant hospitals. So I'm not sure I can answer that question. I would like to know more information about what the person's getting after. So again, feel free to reach out to us at triagecancer.org/gethelp.
And yeah, and let's repeat that. If you don't feel your question was answered or it wasn't answered thoroughly enough to make you happy, please, go on the Triage Cancer site and ask away. Okay. Any insights on how to get back into original Medicare from an Advantage plan? Well, you did cover this. Okay. But this person's been turned down 2 years in a row and stuck on a plan that refuses coverage that original Medicare pays for. Wow. Why would they be turned down?
I have no idea. You can't really get turned down from original Medicare. What might be happening is they might be getting denied a Medigap plan, which then, of course, makes original Medicare challenging because you have to cover that 20% of Part B. So I would again need to know more information to know exactly what was going on there, because you can't get turned down from original Medicare.
Okay. I've paid premiums through my employer for critical illness for 5 years under, it looks like Securian Financial. I guess that's an insurance company. I'm not really sure. They do not consider AL amyloidosis a critical illness. Do you have any suggestion as to how to proceed with an appeal? Well, you just discussed appeal, so.
Well, I did discuss appeals for health insurance where there are some stringent rules. With critical illness, it's a little bit more challenging and you'd have to actually look at the policy language. I think, though, that generally speaking, enlisting the help of your healthcare team to show why it should be considered a critical illness and maybe comparing its severity to other illnesses that the policy does consider critical illness could be helpful.
Great. Are you willing to take a few more questions?
Sure.
Okay, great. Who keeps track of the costs that comprise the OOP out-of-pocket maximum?
The drug plan should do that. But also, you as a consumer should do that. We have a tool on our website called the Medical Bills Tracking Form, which you can actually use to keep track of everything that you're paying out of pocket so that you can make sure that the drug plan is calculating your out-of-pocket maximum correctly.
Okay, what if you take 3 or 4 medicines? What happens to the cost? Well, they all get added together, right? And
correct.
So that's cool. Okay, because most people are taking more
Sure.
than one medicine for sure. Okay. Okay, that's okay. The monthly payment would be $167 per month if they had no deductible in January. If they had to pay the $590 deductible for 2025 in January, the remaining monthly payment would only be $128 for February through December. They would pay $160.
Hold on, I'm going to stop you, because the reason that person's getting the math wrong is that the deductible is on top of the out-of-pocket maximum.
Okay.
So it's the $2,000 plus the deductible plus the premium. And if someone takes a drug in January, they're going to pay that deductible in January.
Gotcha.
That was just an example to show how the smoothing or the payment plan is going to work. Okay.
When open enrollment comes around, how do I get a copy of the formulary for the plan I'm considering before I enroll? That's a great idea, isn't it? To see what drug exclusions are listed and what are tier 1, 2, or 3. When you call, you're usually dealing with a CS customer service person who does not even know how to pronounce most of the drugs. That's for sure true, right?
Yeah, for sure. And I'm guilty of the same thing. So first of all, phenomenal question. And everybody, regardless if you're on Medicare or an employer plan, should be looking at the formulary before they pick the plan. For marketplace plans, they can do that through healthcare.gov. For Medicare, someone could use the plan finder tool. And I think you just have to be an advocate for yourself. If it's not uploaded on the plan finder, then you have to continue calling the insurance company. I will tell you, on plan finder on medicare.gov, you can actually create an account, and then you put in information like your zip code and your age, or your zip code rather. And then you can also put in the drug name, the frequency, the dosage, the pharmacies you go to. And then Plan Finder will actually filter out plans that don't cover your drug. It'll also give you estimated payment amounts. So I highly recommend, if you have access to the internet, using the Medicare Plan Finder tool.
Super. Does the new payment plan mean no more donut hole?
Correct.
Yay. Okay. Okay, it would seem that choosing a Part D plan with a low premium would work the best in order to cover higher cost drugs like Elavil, since the out-of-pocket benefit for 2025 would kick in and cost less overall, correct? I'm confused. Okay.
Yeah, so
I'm-
basically they're saying that with the $2,000 out-of-pocket maximum, doesn't it make the most sense to pick a really low premium Part D plan? And I would say yes, as long as that low premium Part D plan covers the drugs you need.
Got it.
Generally, the plans that are going to have the most number of drugs on their formulary are going to have higher premiums.
Okay. Oh, and this person's referring to your, when you gave the example of Jimmy. Does Jimmy also have prescription coverage?
I hope so. I don't know. It didn't matter for that example because we were just talking about the value of Medigap. And remember, Medigap only helps with parts A and parts B. And because Jimmy was getting IV chemotherapy, that's why it's covered under Part B and the Medigap is helpful. So if it makes you feel better, yes, you can hope that Jimmy has Part D too.
Okay. Do you need to or should you have a lawyer when you get to the admin, law judge, or state appeal?
It can be helpful. Administrative law hearings can be a little bit or a lot daunting. So yes, it can definitely be helpful. And we do have some information on our website about strategies around finding the right lawyer.
Okay, he was referring to Part D drug appeal.
Yeah, and there's an administrative law judge level with A, B, C, and D appeals.
Okay. My Medigap G plan has a special drug prescription program that they claim covers everything Medicare D does, plus more under their plan. It's a special program for retired federal employees. Have you heard of a plan like this?
So I'm going to say, yes, I've heard of it, and it is unique to federal employees because of the Federal Employee Health Benefit Program, which is kind of its own entity. So I don't want to deep dive there, but yes, it exists. And it's likely secondary coverage and not actually a Medigap plan.
Okay. Addendum, the Medigap plan says I do not need to take Medicare D. Okay. Okay. Okay, that would not be a question for you. AMI Centers of Excellence in each state. There's a list. Yes, if you go to our website, amyloidosissupport.org, we do have a list. Or you can send me an email, muriel@amyloidosissupport.org. Send me the state to which you're referring, and we can take care of that question. Okay. Thank you so much for your time and information. I'll be signing up for Medicare starting January 1st, 2025. I'm currently being treated for AL amyloidosis at my local cancer center. In seeing a referring oncology doctor at UCSF, that would be San Francisco, right? And an upcoming cardiologist appointment, it may be determined that I'm a candidate for a stem cell transplant. In my Medicare choices, which plan might you recommend I go with?
Well, I can't tell you which to go with, but what I can share is that if you are somebody who's in a situation who might want to see providers in different places in the country and want to have that flexibility, then Original Medicare is likely going to be the better option for you. If you want to protect yourself from the unknown out-of-pocket, very high expenses that come with expensive health conditions, Original Medicare plus a Medigap is going to give you the most amount of option with respect to providers and the most amount of protection.
I do want to add that Paul has been posting on the chat all these wonderful links to everything that Monica's been referring to. So please, make copies of it, you write it down. It's so valuable. Or if you need any more information from Monica, send me an email and we'll get it to Monica. So not to worry. Okay, we've got two more and then we're gonna let you go. Bless your heart for doing this for us.
Of course.
Okay, will it still be true for 2025 that someone in New York State who had Medicare prior to 2020 can still enroll in a plan F as in Frank for the first time? Ooh, New York is special, huh?
No, it's not. So not that I know of, I could be wrong, but because there are different rules in different states. But my understanding is if you haven't had C or F prior to 2020, those are no longer available to you. I could be wrong on that. So that's something that you could contact your state SHIP program and ask that question directly.
How does it work if you have two private insurances? For example, insurance with my employer and insurance with my spouse's employer. We used to call that double dipping back in the old days.
So interestingly enough, it's actually a really useful strategy if you've done the math to make sure the finances make sense. But essentially, one insurance policy is going to be your primary coverage, and the other is going to be secondary coverage. So one is an initial payer and the other is a secondary payer. Where it can get complicated is in the insurance companies will often argue about who's primary and who's secondary, and there's some coordination of benefits issues. So definitely making sure you've reported both insurances to each other and they know that you're double covered is valuable. And then asking the questions about which is going to be primary and which is going to be secondary.
Okay, one more. Don't type in any more questions, folks. It's not going to get answered, please. Okay. Can COBRA plans be used in conjunction with Part A and B and D?
That is an excellent question with a complicated answer. So it depends on the timing. If someone, let's say, was working and turned 65 and had Medicare because they turned 65 and it was premium free, so they took Medicare Part A, then they decide to retire and they're COBRA eligible. If you had Medicare first, you can also pick up COBRA, and it could potentially be like a secondary plan. If, however, you get COBRA first, like you have COBRA now, and then you turn 65, COBRA ends and Medicare starts. You do not get to keep both. The challenge, though, even if someone could keep both, is that when COBRA ends, that does not trigger a special enrollment period to pick up a Medigap plan. So then that person is now going to try to potentially purchase a Medigap plan. They could be denied, charged more, or face that 6-month exclusion period. So think very, very carefully before keeping COBRA and not getting a Medigap plan. I will also tell you that that is a very simplistic answer to a really complicated question. Medicare has an entire booklet called Who Pays First. So it gets really complicated when there's multiple levels of coverage. It doesn't mean you shouldn't have it, but just know that that was a relatively simplistic answer.
Well, you've made a lot of new friends today, and people have been sending messages and thanking you so much for all the help that you've done, and we can't thank you enough for giving. I know in addition to all the other things I listed on your resume, you're also a mom, and so we really appreciate everything you've done for us today, and we want to thank you so much. And Bob will make sure that these recordings will be up on our YouTube channel and our website, and we'll post them in our Facebook group so everyone will have copies. Please take part in the survey. That's so important. I have a feeling we're going to hear lots of nice things about Monica for sure. Also, Paula will get that on One Amyloidosis Voice as well. So stay safe, everybody, and thank you, Bob. Thank you, Paula, who went above and beyond. We appreciate you taking part in today as well. So thank you, everyone, and have a wonderful day.